Welcome to the Mill Valley Library, and thank you all for coming out here tonight. My name is Deborah Schwartz, and I'm on the board of the Historical Society in charge of the Oral History Program and co-in charge of the First Wednesday Speaker Series, which is tonight. Can you hear me okay? No?
Speak into the microphone.
How's this?
Perhaps better.
Good. And we're recording this, right? Okay. Tonight, I feel very fortunate to have Dr. Victoria Sweet here to talk about the history of medicine, something that may seem like a slight departure from our usual discussions, but really, medical care has always been an integral part of our collective history, locally and worldwide. First, as always, I'd like to thank the Mill Valley Library for allowing the Historical Society to host our First Wednesday Speaker Series here. So, thanks to the library. And I would also like to thank all the members of the Historical Society for your support and your contributions. Your membership allows us to do so many things, and it's not very expensive, is it? Less than $20 per year, such a deal. But it allows us to do so many historical projects in town. It allows us to put on events and programs such as this, and of course it finances our annual history walk. So thanks to all those that are members. Hands up to who are members here. Oh, and for those that aren't, it's an easy click on our new website. Please check it out. Before we begin, here's a little basic breakdown of how the night's going to go, and most of you already know this, but for those that don't, Victoria will begin with about 45 to 1 hour presentation, and then we'll have 15 minutes of Q&A, and then we're going to have a special guest musical appearance. I love to have music with these events, a little talkie, a little music. It's just a nice pairing. And our special musical guests are Matt Lax and Kay Rodden, and they are out here, but you will see them up later today. After the music is our time to schmooze and connect with each other in Victoria while we put away these chairs. And we'd love to have your help with that. Those that have been to these events know that this is our way of showing our appreciation to the library for allowing us the use of the room. So thanks in advance for all those who care to help us restore the room to its natural order. History is a link, a route, a channel. Time holds us to each other like a conglomerate of rock or rings in a tree. Each year, each decade, each century, in its own place, yet in the same grand mass. When we reinsert ourselves into the past, we can re-examine what was really valuable at any particular time, and if we choose to, bring it back to the present, and hopefully ensure its place in the future. Victoria is here tonight to discuss an important part of this country's healthcare system, the asylum. That sometimes sacred, sometimes scary place where the sick and poor were treated, whether it be in a county hospital or an almshouse. How many of you remember such institutions? And when they went away, and why? Tonight, we are going to go back into history as Victoria examines the concept of someplace to go versus no place to go. Victoria is uniquely qualified to help us understand this complicated issue. She's a real California girl, 4th generation. Her family came here during the gold rush. She's a Guggenheim Fellowship recipient, an associate clinical professor of medicine at UCSF, and she spent 20 years practicing medicine at Laguna Honda, which is the setting for her amazing book, God's Hotel. Out of curiosity, how many people here have read this book? How many people in this room are in this book? Victoria's new book, Slow Medicine, has just come out. Really good. So, shall we begin? Let's together go back into time with Victoria's help. Before Trump care, before Obamacare, before health care replaced medical care. Back to that time when the first idea that institutionalized treatment, care for the sick and dying, should be freely available to all. So without further ado, let's give a warm welcome to Victoria Sweet.
That'll be okay, if you have to leave at 8:15. I heard her. Well, thank you. Oh, I have to, stay near this, don't I? Can it? And could you leave the lights on, or mostly? Let me just kind of get adjusted here. I like to see everybody, and I actually like to walk around with the mic. Is that possible that I can walk around? Sure. It helps me. People here who know me know I'm a kind of restless person, which is of course why I came up with the idea of slow medicine. No slow person would have come up with the idea of slow medicine, trust me. So first of all, I'd like to thank you all for being here today. Taped. I'm taped? Oh, I'm taped on the floor. Oh, yeah, I'll pull that up and give you a little more room. It's okay. This is fine. Okay. This is fine. Yes. So, I want to thank you all for being here. I always find it hard to get to places like this unless I'm the one who's speaking. Even then, sometimes I'm kind of wishy-washy. And I'd also like to thank Deborah for having put this all together. It's amazing. It's a beautiful program I think she's put together, and I'm looking forward to hearing the music. And I'd also like to thank the Mill Valley Library. I've never been here before. And I think of myself as sort of an aficionado of libraries. As you will hear, many of my most exciting things have taken place in libraries. But I've never been here before, and I have to tell you, this is amazing. It's amazing. I haven't seen that much koa wood since I was in a sculptor place in Mendocino. It's just gorgeous out there, and it's filled with people using it, which is thrilling, and it's filled with books, actual book things. So it seems like just a great resource for the whole community. So what I thought I would do today is, or tonight really, is, so I changed the title a little bit because I have to tell you I had kind of a hard time putting together this talk because I didn't want it to be just history. I wanted it to be what history is for me, which is history's importance for the present, history's meaning for the present, history being present. And so it took me a while to figure out a kind of balance between how much history I wanted to do here and how much reference to the present and the future. So I'm going to talk for about 40 minutes, actually. So there'll be plenty of time for comments and questions. For me as the speaker and a writer, I love this part of the questions and comments because I get a much better sense of where people are coming from. So what I thought I'd do is I've divided the talk in kind of three in my head. So first is I want to tell you a little bit about myself and how I got here. Then about this very unusual hospital where Dr. Fricker and I both practiced for many years, Laguna Honda Hospital in San Francisco, and what it provided me and what it provided its patients. Then I'm going to tell you about a woman who changed my life from the past, a 12th century abbess, and what I learned from her about healing. And last, I want to talk a little bit about what I see is actually going on today. So we've got a kind of past, present, and what I would like to see in the future. So that's kind of how it's structured, about 40 minutes. So I want to start by talking a little bit about myself. So I think the first thing you should know about me is I am a doctor. I'm an internist. but I've never considered myself to be a natural-born doctor, you know? Growing up, I had a friend who was a natural-born doctor, you know? She watched all the doctor shows, and if there was anything wrong with you, she wanted to hear about it and look at it and touch it, and she volunteered in hospitals, and I wasn't like that at all. I didn't want to have anything to do with bodies growing up. I didn't want to see it. I didn't want to hear about it. And in fact, when I told my family I was going to medical school, they were absolutely shocked. But what happened is that toward the end of college, I discovered the writings of Carl Jung, the psychiatrist. I discovered his memoirs, Memories, Dreams, and Reflections, serendipitously in a bookstore. And I was entranced as I read it. I loved the meaning he demanded from life, the meaning he brought to the life of his patients. And I particularly liked how he set up his own life, seeing well-paying, neurotic, articulate patients in the morning, and illuminating manuscripts and studying alchemy in the afternoon. I thought that would be just a great life, so I decided to go to become a Jungian analyst. And at the time, you had to go to medical school in order to do that, so or PhD, but I decided to go to medical school. And it turned out, and that's how I got to medical school, and it turned out I liked medical school a lot more than I thought I would. Especially those last 2 years, and by the way, are there docs in the audience? Yes. And nurses? Good. And therapists and people, social workers, and yes. So those last, medical school is 4 years. You need 4 years of university, then 4 years of medical school. And the first 2 years are sort of medicine is science. You do the science. And the last 2 years, you get to step into the hospital. And I found that I really liked those last 2 years. I particularly liked, surprisingly, what we call the workup, the taking of the history, asking the patient why they were there, figuring it out, partly because there was so much psychology to it, You really had to listen to what the patient said, and how they said it, and what they didn't say. And then it turned out I really liked the physical exam. I liked touching people, mostly because the physical exam, I could figure out so much of what a patient had or didn't have just by examining them. And then there was going through the labs and the x-rays and the consults and putting it all together in the assessment and the plan and the differential diagnosis and the treatment. I thought it was a brilliant method. But I still continued my first idea, which was to be a psychiatrist. But I was a bit naive. I ended up starting my psych residency in the only locked ward in that particular county. So my patients did not turn out to be Jung's well-paying, neurotic, articulate patients. They were all severely psychotic. And they responded really much better to the medications I used than they did to the talk therapy I tried. So after that first year, I got my license, my medical license, and I decided I was just going to go out and practice medicine and see if I liked it or not. And I ended up practicing for several years in a county clinic, not too far from here, across the bay, right near Stanford, and I loved it. It was so fascinating, because anybody who's practiced in a county clinic or a community clinic will know you get everything and everybody just walks in. Many people are immigrants, so they bring their diseases with them. I saw, 4 miles from Stanford, I saw 3 cases of leprosy. I saw every parasite there was, and many really unusual diseases and interesting cancers. So I decided I really liked medicine after that experience, and I went back and did a residency in internal medicine in San Francisco, right in the middle of the AIDS epidemic, which was a horrendous experience, but also, from a historical point of view, quite remarkable. Suddenly we had a disease, an infectious disease. We didn't know the cause. We had no treatment. We didn't know what was going to happen. And after that, I finished that, I actually went back to the community clinics for a while because I liked that kind of work. And the more I practiced medicine, the more impressed I was by our modern medical way of arriving at a diagnosis and a treatment, our methodical, logical way. But I was also more and more impressed by what modern medicine left out, which was anything that wasn't logical and methodical. So I began looking into things like the doctor-patient relationship or the placebo effect or this whole thing that happens between a patient and a doctor. And I looked at naturopathy. I was looking for alternative ways of looking at the body that would subsume these different concepts. And so I looked at naturopathy and homeopathy, Chinese medicine, Ayurvedic medicine. And for a while, I actually thought about learning Chinese or Sanskrit so that I could read these texts in their own language and really be able to understand them from the inside. But eventually I decided I wasn't Chinese or Hindu, and even if I did that, I didn't think I would really be able to understand these different ways of looking at the body from the inside. So it was at this rather discouraging moment in my life that I discovered the writings of a woman who changed my life. Her name was Hildegard of Bingen, and I discovered her works in the HQ section of the library, which is the anthropology section. I don't know why she was there. But her book just popped out, and it was called Hildegard of Bingen's Medicine. And it had just been translated from her Latin into German and German into English. And as I read it, I was amazed. She was a 12th century abbess, a nun, a composer, a mystic, a theologian, and she was also a 12th century medical practitioner. And she'd written this book about her medicine, and what intrigued me, was it wasn't the Eye of Newt, Toe of Frog medicine I expected from a medieval medical text. I could tell it was a real medicine with prescriptions and all that for real diseases that I could recognize. But it was based on some completely different model of the body from my modern mechanical model. I couldn't quite put my finger on it. It was much more like the Chinese or Ayurvedic. And I wondered if it was the missing piece of Western medicine. So at that moment, I decided I was going to go back to school and get a PhD in history of medicine with Hildegard of Bingen as my focus. But I didn't want to stop practicing medicine. I wanted to do it half the time. So I spent actually a couple of months looking around for a job, and I finally found one at Laguna Honda Hospital in San Francisco, which was the only place that was willing to let me, at the time, practice medicine part-time. And when I drove over to, how many of you have ever been in the old Laguna Honda? Yes, I would like to point out, just for those who imagine this was happening 50 years ago, we moved out of that old place into the new place actually 7 years ago tomorrow. Yeah, that long ago, 7 years ago. But up until 7 years ago, this is where we were practicing. This is where I spent my whole 20 years practicing medicine. And when I drove over, I'd never seen it before. When I saw it for the first time, I was really taken aback because it looked like a 12th century monastery. It had cream-colored walls and a red-tiled roof and turrets. And then I went for my interview, and then the medical director took me out for the tour. And the place was just, I'd never seen anything like it. It was on it still is, on 62 acres of land right in the middle of San Francisco. At the time, it had 1,178 patients. And it was a fascinating place just to walk around. The medical director took me to the surgical suite, so this building was built in the 20s, in 1926. So there was a surgical suite that was built facing north because they really having electric lights and big old lights was not that common. She took me to the X-ray department, which had an X-ray machine that we doctors could basically tell people exactly what X-rays we wanted. That had been a very big novelty in 1933 when it was put in. We walked around. She showed me the lab. It had a microscope where we could look at our own slides and stain them. Then we walked past this 1950s, modern, era beauty salon with the steel helmet hairdryers. And then she took me to the chapel, and this is a city-run institution. And the chapel was really more like a small church. It had stained glass windows, polished wooden pews, an altar, and very politically incorrect stations of the cross along the walls. And then we went outside, and she showed me the grounds. There was a greenhouse so that patients could pot plants. There was an aviary, a handmade aviary. It was just remarkable, filled with birds, and so that patients could actually watch chickens hatch from eggs in incubators, even if they were unable to get out of their beds. And there was a little barnyard with black pigs and rabbits and chickens, which the physical therapists would dress up for Halloween and Thanksgiving. Little turkey, you know, there was a little turkey, then have a little pilgrim hat on it, and move this little cart around the hospital so patients could actually see animals. It was just remarkable. Then we walked back, so I had this whole tour. We walked back to her office, and she offered me the job. I have to say, and so this is actually fun for me because as we were walking back the office, who was running out of the door? I don't know if you remember, Anne, but who later I found out to be Dr. Anne Fricker, but at the time I thought you were this young, innocent intern. And so we walked back to the office, and I was offered the job, and I really thought for quite a bit about it. I was like, this is like no place I had ever seen or even imagined. But it was the only place that was willing to let me practice medicine part-time. So I told the medical director I would come for 2 months, and I ended up staying for 20 years. As it turned out, almost everybody there ended up doing. I started realizing when I was running God's Hotel that I wasn't the only person to go for a month or a year. I never met anybody who had started Laguna Honda with the idea of being there for longer than a year or two. And then I talked to people, I said, how long did you just thought you'd be here when you first got here? Oh, just till my son got out of elementary school, or, just until, we settled down. And I say, and how long have you been? The person would go, 40 years. The longest person I met was the chef who'd been there 50 years. And so I ended up staying there for more than 20 years. And why? Well, there was a couple of reasons for that. And part of it depends on the historical piece of Laguna Honda. And here's where we got to some of the history and the sense of place that I want to tell you about. Because Laguna Honda turned out, had a long history that goes quite way back. It was originally the San Francisco almshouse. And the almshouse was how we used to take care of the sick poor before there was health insurance. And it goes all the way back to before the Middle Ages, to right after Rome fell apart. This is how I actually got the name for my first book, because in French, the word almshouse is Hotel Dieu, God's hotel. And this idea of taking care of the sick poor at all is not an obvious, necessary cultural idea. It's very specific to the West. It began after Rome fell. So Rome didn't have anything like we have. Didn't have a county hospital or an almshouse or clinics or any sense it should take care of the sick poor. I mean, if you were a leper, you just sat on the steps of the forum and hoped somebody gave you money. But what happened was, as Rome was collapsing and Christianity was arising, the monks took on this idea, and the nuns took on this idea that taking care of the sick poor, or anyone who knocked on the door, was the essence of their vocation. And it came from this quote from Matthew 25, which I'm going to read you, because this was the beginning, this was the essence of the matter. For I was hungered, and you gave me meat. I was thirsty, and you gave me drink. I was a stranger, and you took me in. Naked, and you clothed me. I was sick, and you visited me. I was in prison, and you came unto me. Inasmuch as you have done it to one of the least of these, my brethren, you have done it unto me. So this notion that taking care of the sick is a vocation, is a calling, was deeply rooted in Western culture. And it's why, to this day, we even have this weird notion we should have something called Medicaid or Medi-Cal or Medicare. This is not particularly obvious. And in the West, the image I picked to illustrate this point is really gorgeous. This is from the Hotel Dieu in Beaune. I don't know, how many people here have seen this? few people. It's just remarkable. So this looks like a church, but it's actually their almshouse, the Hotel Dieu, the God's Hotel of Bones in Burgundy. And it was a working almshouse taking care of the sick poor until 1973. And you can see the references. It looks like a church. And these are beds for patients that line the walls. It was this reason that we had the picture of the open wards that some of you remember from old-fashioned books and movies with the 36 patients on the ward, the old Nightingale wards. This was why they're this shape. And there's an altar at the end in this particular really beautiful place that's worth seeing. And one of the interesting things for me when I visited was to see that privacy was maintained because instead of putting the beds perpendicular to the wall, they put them parallel to the wall and had a little curtain that patients could close. And it's just like in a church, there were windows along this. So everybody had a window. Everybody could have privacy. But if they kept their curtains open, they had the benefit of the whole craziness of the ward if it was anything like Laguna Honda, which I expect it was. So this is the notion that began our whole idea of taking care of the sick poor, and it continued for a long, long time. I wanted to put this also. This is the seal of the Hotel Dieu in Paris, and I love this. I translated this when I found this. This is from its its convention. What do you call it in English? It doesn't matter. It's a list of laws about how it was going to run. So this was written in about 1170. It was Latin, but it wasn't hard Latin, so I translated it. And what I liked about it is this. This is who the God's Hotel were supposed to take care of, traditionally. Soldiers and businessmen, monastics and lay people, Jews and Muslims turn in their need to God's Hotel, and all are received because each carries the sign of poverty and misery. One asks for nothing more, of little importance which God they serve, which illness has struck them. So during the whole Middle Ages, this was how the West took care of their sick poor. Monasteries all had the monk infirmarian who took care of sick monks or sick nuns. And there was also a hospice, which wasn't what we think of hospice. It's a hospitium, which would be part of the infirmary. That would be in the wall of the monastery. So the first thing you would meet when you got to the monastery was the monk infirmarian who would take you in if you were a pilgrim, wash your feet, let you stay, take care of you if you were sick. If you were an unmarried pregnant woman, you could go. If you were an orphan, you could go. If you were a lunatic, you could go, and you would be taken care of for free as part of their vocation. So all across Europe, this was how it worked. And I put this picture in because even in England today, there's still some remains of this. This is St. Cross in Winchester, which I had to visit because it's been there. It was established in 1129 by, I think it's Henri de Blois. These are where the sick and elderly would live. They each have chimneys. And Henri de Blois established this for the care of elderly men, and he set up a fund for 12. There were, I can't remember the name, they're the Reds, the ones wearing reds. There were 12 of the red guys wearing the reds and 12 of the blacks. And it's been going on since then. Since 1129, it has taken care of 24 men and taking care of them. They have their own little house, little apartment, food, drink, and medical care until they die. And the other piece of the reason I wanted to go there was because since 1129, there was also a rule that if any pilgrim or traveler knocks on the door, you'd get a cup of ale and a little loaf of bread. And of course, I had to see whether that was true. So I walked there as a pilgrim and I knocked on the door, and indeed, I gave me a little cup of ale and a little piece of bread. So that was how it worked. And then came Henry VIII, 1536. And if you need any more information, you should actually raise your hand, or we can talk about it later. But so Henry VIII was, King Henry. We all know him, about his 6 wives who died and survived and were divorced and beheaded. And he had the big fight with the church. And one of the things he did in 1536 was dissolve the monasteries. He made himself head of the church in England. And one of the reasons he did it, because by then, the monasteries were incredibly wealthy. They probably had about a third of England's wealth. People would die and give them money, and since the monks weren't supposed to have children, none of this money got spread around. It was all concentrated. And Henry had his eye on it, so in 1536 he dissolved the monasteries, took all the money, threw all the monks and nuns out. And what was interesting to me, from the point of view of the present, is it took an entire generation. It took until Elizabeth's time, his daughter, till anybody kind of realized what a loss this had been. And it actually reminds me a lot of what happened with our state mental institutions, okay, which were dissolved effectively in the 1980s. And it took us about 20 years to realize, oh, is that why all these mentally ill guys are wandering the streets? They don't have any place to go. Same thing in Elizabeth's time is really interesting. It took a while for it to happen. And then somebody looked around and said, oh my God, we've got all these sick and poor and elderly and demented and mentally ill people, and we have no place for them to go. So it was at that time that Elizabeth set forth it was called the First Poor Law, first Elizabethan Poor Law, where she made the counties, so that instead of the monasteries, the counties, from then on were responsible for their sick, poor, their elderly, and people couldn't manage. And that is brought to the United States, and that's why the counties today are responsible for their own sick, poor, and have been traditionally. So that was brought to the United States, and the way we did it for many years was that every county would have a county hospital that anyone could go to who was acutely ill. If you got sick and had appendicitis, you just show up at the county hospital and they take you in. And then if you needed longer-term care, if you needed more care, you had a stroke, chronic care, rehab, or if you were unemployed, or if you'd just been out of prison, if you were an orphan or mentally ill, you could go to the almshouse. It used to be that every single county just about in the country had this same setup. And then what happened was that starting in the 1950s with the publication of Goffman's book on asylums, where he talked about institutionalization, and also the fact that most of these places had been built when the cities were just starting, so that by the time everybody woke up, they were occupying some of the most valuable land in the city. So around the 50s and then in the early 60s, there was a movement to shut first the almshouses and then the county hospitals closed. And this is in fact what happened in Marin, because being a county, you had an almshouse as well. I really tried to find a picture, and I'm not sure that this is a picture of it actually. But you did have it was called the Poor Farm, sometimes it's called the Poor House or the Almshouse. And like every other county, Marin established it in around 1880, and it had a farm, like Laguna Honda had a farm. It had a hospital. It took care of the sick poor. It was a kind of cool place. And then in the 50s, it was discovered that it had problems with the earthquake, and there was actually a bond to rebuild it, and the bond was not passed, and eventually it was taken apart, and the land was used for something else, and there's no longer anything like that, I believe, in Marin. But Laguna Honda and San Francisco had a bit of a different course. So, and I have ideas about why the course was different. Because Laguna Honda was also founded as the San Francisco Almshouse in 1862, when San Francisco was founded. It's part of the charter of San Francisco. And it has been a pet, really, a pet interest of San Franciscans ever since then. And one of the interesting things for me as the doc there was that not only did the place kind of embody its history, but amazing records have been kept of Laguna Honda. So while for Marin, I don't think there's hardly anything left, San Francisco has just unbelievable records. And I'll give you one example. I'd been at Laguna Honda about 5 or 6 years, and I was meeting in the social worker's office about a patient. And I'm sitting around, and of course this building's from the 20s anyway, with the wiggly glass and the windows that open. And I look over and I see on one of the chairs is this pile of books with like gold writing and leather. They're about this big. So I go over and I open one up, and they are the hospital's register of patients from 1877. It was amazing. I just started looking. It was fascinating, right? You could see the nurses' convent italic writing, why somebody, their name, where they were from. This was the entire hospital record, by the way, as far as I could tell. The name of the person, why they were admitted, their birthday, where they were from. Very important, very interesting. You know, what country they were from. Their admitting diagnosis. And if they, and then what happened to them for that year. So the choice mostly was died or ran away. And Laguna Honda sort of maintained this place in San Francisco's heart. And some of it, I believe, has to do with this man who I admire greatly. His name is Charles Wollenberg. And he was the superintendent, that's how they used to manage the place, the superintendent of Laguna Honda starting in 1906. He was a pharmacist. He was 22. It was the day of the earthquake. He had a pharmacy downtown. Everything was burning and collapsed, and he'd managed to get one of the last horses and buggies, and it was driving downtown, was in the middle of Market Street, trying to see what happened to all his stuff and get all his medications. And along comes General Funston and says, "What are you doing, young man, with that carriage?" And Wollenberg said, "Well, you know, I managed to get the last carriage, and I'm trying to get my meds and see what's left." And he says, "I'm putting you in charge of the medical care for the entire earthquake. Anybody with that kind of gumption should just do it." And that's what happened. So Wollenberg, at 23, was in charge of all of the medical care of what happened. Of course, as many of you know what happened, there was the earthquake, but then there was the fire that was many homeless people. So he was the one who set up everybody in the park, in Golden Gate Park. And gradually everybody kind of went away until there was this group left that probably had been homeless before, had no homes. So for about a year, he put them at the racetrack. He moved the horses out of the stalls and moved the patients in. And then he got money given him from all over the world, and they rebuilt Laguna Honda a couple of times until in the 20s he had it rebuilt in the beautiful way that we're used to. And I put this in just because this picture, this fact really interests me. So this is a wall that surrounds Laguna Honda to this day. If you go there to visit, you will see this very wall. And you will go in, you'll see there was a gatekeeper's, it's a gate, the gatekeeper's house. And what I get a kick out of is it's made out of the cobblestones of San Francisco. Because in 1917, they were ripping up the cobblestone streets. And Wollenberg found out about it and said, "What are you doing with all those stones?" And they said, "Oh, I don't know." He says, "I want them here because I want to give my patients who live here something to do. Because there's nothing worse for people that aren't sick than nothing to do." So it's the patients who built this wall, and it goes all around the entire place. That's the kind of guy he was, and I have a whole Wollenberg thing, so I can go on for a long time, but I don't think I will, because I want to move on here to what I learned when I was there and why I stayed so long. And I think of it sometimes as the efficiency of inefficiency. So Dr. Fricker and I were some of the admitting doctors. I was the admitting doctor on the wards, and we were in those long open Nightingale wards, and we'd get about 3 or 4 patients every day, usually from the general hospital. And the remarkable thing, first of all, was the patients themselves. Because typically, the almshouse will get the bottom 1/10 of 1% of a city's population. Consequently, I found to be true that they were 3 standard deviations from the mean, from any mean. They were literally the tallest and the shortest, the fattest and the thinnest, the oldest and the youngest, the smartest and the least smartest patients I ever had, and the nicest and the meanest. And the other thing about having an almshouse crowd is that because it's a catchment area in a way, San Francisco at the time had about 550,000 people. If a disease happened in 1 in 100,000, a rare disease, we'd see it. we might see 2 of cases. So it was fascinating from a medical point of view. And I saw everything just about in my Harrison's Principles of Internal Medicine. But the other thing that made me stay is that I had time. This is where the time piece can. So we've talked about the space piece, right? Everybody had someplace to go, even if you were down and out. But now's the time piece. And I, as a doc, and our patients as patients, we were over the hill to the poorhouse. So for all that time, nobody really paid that much attention to what we were doing. They paid more and more attention, and we had rules and we had regulations. But basically, when I got a new patient, I could spend the 2 to 3 hours it takes to really examine a patient and figure out everything you possibly can about them as you start. You know, what medications they really need. You start getting, say, what are their real diagnoses? Call the hospital, get their records, talk to the family, fully examine them, have an idea about what they might need, and then re-examine the next day or the day after that. So it was an amazing experience because I would see, for instance, that most of the patients that I would get at Laguna Honda would be on, I kept track, on between about 15 and 26 medications when they would come in, of which they actually only needed about 4 or 5. But nobody had ever had the time to go like, wow, you know, why are you on this prostate cancer medication? And try and track down why they were on it, right? It was easier to just leave them on their medication for your 15-minute visit and move on, or your 2-day hospitalization. So most of the patients that I had, I could take them off about 10 to 20 medications. And of course, the patients did much better off all those medications. And I had the time to go through the diagnoses and figure out what they really did have and what they didn't have. And the nurses had enough time to treat their decubitus and shave them and buff them and polish them and, you know, do their nursing care. And the social workers had enough time to find out what their resources were, maybe to visit their place that they used to be in, to try and figure them out. We all had enough time, and the patients had enough time to heal. And eventually this would be called very inefficient, but what I started calling it myself was the efficiency of inefficiency. Because if you think about just me taking somebody off 10, not just me, all of us did this, most of us, 10 or 15 medications. If you think about somebody getting a medication, it was at least $5 a day, $10 a day if you're adding in adverse reactions, labs, et cetera, that's about $100 a day you're saving the system over the course of years. So I began to think of this as the efficiency of inefficiency, and it's one of the consequences of when we all have enough time. What am I doing on time, speaking of time here? I want to tell you a little bit about my PhD, because while I was doing all this, I had gone back to school and gotten my PhD. I was getting it in Hildegard of Bingen, who was this 12th century abbess, as I told you. You want to turn that down just a little bit? The light down a little bit? Maybe just a little bit here, because this is a really beautiful piece. Hildegard of Bingen. Yes, sorry about that. So Bingen is a place in Germany near Mainz on the Rhine River, and Hildegard was actually from near there, so she began to be called Hildegard of Bingen. And this is a manuscript folio from about 1220, a little bit after she died, and she is in the corner here getting inspiration from God and writing her books on these black wax tablets that they had in the Middle Ages. So you can turn it, I just can. So I spent quite a few years studying Hildegard because I wanted to understand her medicine from the inside. I wanted to understand it as if I were her student. So I wanted to read her in her original. So I took Latin and medieval Latin, and because they were all handwritten, I took classes in paleography and codicology, and I started looking at whether anybody else had written about medicine back in the 12th century. I found about 80 manuscripts there were 80 other people who did, so I tracked them down. I went to England and France and Switzerland and looked at their manuscripts and sort of tried to get a sense of what her medicine was about. And just to also get a sense, because I'm a practical person, I decided to plant a medieval garden, a medieval Hildegard herb garden, and I also tried making some of her recipes. I whipped up some of her candies, I baked her antidepressant cookies, and I brewed her medicinal beers. And gradually, over several years, I began to get this sense of what was different about Hildegard's model of the body from our own mechanical model. So our model, really, you can think of it as body as a machine. And I love this poster from Fritz Kahn from 1923, or really a collection of machines. So for us, really, the brain's a computer, and the lungs are bellows, and the heart's a pump, and the kidneys are filtering device. And in this model, the doctor's a mechanic, and our job is to find what's broken and fix it or replace it. For Hildegard, the body was much more as a plant. What's the difference? Well, the difference is that someone else has to fix a broken machine, but a plant can heal itself. And Hildegard had a name for the power of a plant to heal itself. She called it its veritas, from the Latin veritas, that means green. And there's this greening power, this growing power. And this was a concept that was very well known, but what Hildegard did with it was quite different, because she believed that human beings had their own veritas, and that the job of the doctor, was more like a gardener, and that the job of the gardener was to remove what was ever in the way of veritas, and then to fortify it with the basics, which the Middle Ages thought of as, good food, sleep, rest, and sunlight, or Dr. Diet, Dr. Quiet, and Dr. Merryman. So I began to apply this model along with my model of being a doctor as a mechanic, a logical, methodical doctor, which works really great for what I think of as fast diseases. If you get hit by a car or have an appendicitis, I don't want to have a Hildegard's model of the body. But after and before that happens, her model of the body, I found, was quite helpful way of looking at my patients. And I began to think of it as slow medicine, kind of in contrast to the fast food model of healthcare we have today. Although I really find that both of these models, this idea that the body's a plant and that I'm a gardener, moving things out of the way, putting the patient in their environment, and this sort of fast model of me as a mechanic, finding what's broken and trying to fix it, sort of this focusing down, that they actually work both when I use them together as two complementary ways, two different ways of looking at my patient. Well, by this time, Laguna Honda had been discovered by over the hill to the poorhouse. One day we looked up, and healthcare efficiency experts arrived and were horrified by what they saw. The aviary, the barnyard, the greenhouse, the live-in nun. They were horrified, but they were really horrified by those open-fashioned Nightingale wards, because, as it turned out, as the Department of Justice told us when they arrived, shortly thereafter, that we all have a civil right to privacy. I wish I'd known that when I was in college. And that Laguna Honda was violating our patients' civil right to privacy because they were on those big open wards. So the Department of Justice demanded that the city close the place down or finance a huge new bond to rebuild it. Just this kind of thing that happened in Marin in the 60s. But unlike Marin, after about 10 years of fighting, San Francisco did pass a bond, 2-to-1, to rebuild the place. And a short 8 or 9 years after that, the place was built, and we moved into it about 7 years ago. And I took time off, actually, at that point, because I wanted to write a book about it, because I had a feeling that by the time the place was taken down, which was the intention at the time, the old place, that nobody would believe what it was like, really, the good as well as the bad, mostly the good, actually. And I also took time to think about what I'd learned in my 30 years, really, of practicing medicine total, and what kind of changes I'd been seeing in our healthcare system. And what struck me is it seemed to me that the pendulum has been swinging from what works, okay, to what makes money. from relationship to profit, and from the personal to the efficient. And I have been ever more impressed by how inefficient all this efficiency is. No matter what these guys and women come up with, the healthcare economists, every year our health costs rise. And you'll notice this is not just the United States. Everybody's costs rise, no matter what they come up with, all the DRGs and the HMOs and QAs and MIPS and memes. Everything they come up with, every year relentlessly costs rise. And nobody exactly knows why. So what I want to do is kind of wrap things up, or start to wrap things up right now, with what I do know happened at Laguna Honda. So at Laguna Honda, what happened in the 20 years I was there, as an efficiency measure, as a way to save money, is that the number of patients we took care of was cut from 1,178 down to 780. And correspondingly, the number of doctors were cut, full-time FTEs, from 32 to 9, which was actually fewer than the number of full-time quality assurance managers that was there, which was pretty scary when I realized that. There was more than one of them. That's actually when I decided to leave. I was walking down, I was counting them, I was going like, whoa, they could assign one of those guys to me personally. They could just follow me around and decide what I was doing wrong, and I was having to actually do the thing, and all they had to do was say what I did wrong. I did not like that. And the clinical staff was also cut from about 1,500 to 1,200, okay? All in the interest of efficiency. But every year, the budget rose. Why was that? Well, when I looked in it more carefully, I found that even though the patients went down and the docs went down and the clinical staff went down, the total number of patients, of staff, was about the same. There were more and more administrators every year. And what did all those administrators do? Well, it was hard to know for sure. But the one thing we had more of at Laguna Honda on the day I left than the day I arrived were forms. When I first got there were literally 2 single-page forms in the chart. The day before I decided to leave, I pulled a chart out. We had paper charts, which was kind of nice because you can go through them. And I just counted. Random chart, I just counted. There were 43 forms. And none of them were one-page forms. They were 3-page forms, 5-page forms, 20-page forms. There were so many forms that the charts would explode and medical records would have to come up and take out the doctor's notes to make room for the forms. This is the little napkin-y thing I did at the time to try and clarify my own thinking about this issue. So here are the patients going down, and here's the docs going down, and here is the total staff staying about the same, and here's the budget going up, and this is the number of forms. And as you can see, if present trends continue, by 2024, there will be no patients at Laguna Honda. There'll be 2 physicians. There'll be 1,400 staff, a budget of $275 million, and an infinite number of forms. I call this doing less with more. And it's exactly what's happening around our country, the same exact thing. I'll show you. So this is a kind of cool graph that charts growth of physicians and administrators. And it's a little bit hard to read, so I'll explain it to you. This is percentage of, numbers from 1970 to 2009. So the brown is the increase in the number of docs. And looked to me like it was about double. That it had just about doubled, maybe 200%, 100% or something, which is about in context to the population growth. So you could say there's about the same number of docs, patients per docs, as we've always had, more or less. The yellow is the administrators, okay? It's 35 times as many administrators. Just as Laguna Honda, you see whatever way you look at it, goes up, 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 up. What do all those administrators do? Well, again, it's hard to know for sure, but we do have one sense of HHS paperwork in millions of hours. okay, from just in 10 years, doubled. And that has led us today to the situation where this is the sentence I have heard in every single talk, and I've given hundreds of talks now, all over the place, all over the world. Somebody raised their hand and goes, "My doctor doesn't look at me anymore." And the sense to me as a doc is, why not? Why don't we look at them anymore? And this is what I chose here to illustrate this was turned into a rather scandalous child's drawing that appeared in JAMA about, I don't know, 7 or 8 years ago. A little girl did it, and her mother sent it into JAMA. She gave it to her mom, and she said they'd just gone to the doctors. So she'd come home and visit to the doctors. "Mom, I drew this picture." So there she is, she's sitting on the exam table, and there's a mom holding a baby, and I think she's with a friend, and there's a little ball or whatever, and there's the doctor sitting in front of the computer. So then it begs the question, first of all, we need to put inefficiency, unassigned time, back into healthcare. I don't believe that until doctors and nurses and therapists have our time back with patients, this certain amount of free unassigned time, I don't think any QA measure, any sticks, any carrots can do anything. Most of the docs, nurses, and therapists I know want to do a good job. We want to take care of patients, and we don't have the time anymore, and we need to get it back. And the reason I have this in here is because I had this visual of it's like this toy I had when I was a kid, where I'm sure many of you here know this toy. You're supposed to line up all the numbers. But the only thing that makes this toy work is that empty space. That's what allows it to move around. And when we don't have the empty space we had at Laguna Honda, we had that little extra time where we could sit on the bed or talk to the patient or find out some crucial item you would have never found out if all you're doing is sitting in front of the computer figuring out, filling in forms. So we need to put space back into healthcare as well as time. We need to mend this hole in our safety net that was left when Henry VIII in England dissolved the monasteries, and when we started to dissolve our state mental health institutions, our almshouses, many of our county hospitals, places where people can go when they're down and out, because we all know we can be down and out too. And then the question is, can we get this back? How? And I think I have time. Okay, so I've done a lot of thinking about how. And one of the things I thought of, first of all, I do think we need asylum. We need, I think that the county hospital, county almshouse, state mental institutions, we need something like that. Even if they're not fair, even if they're not perfect, even if they're merely adequate, we need these kind of places so that when you slip through the safety net and the next safety net and the next, you still can always knock on the door and be welcomed inside. So this was, I think it's gonna do that. I'm gonna skip that one too. And then the second piece, what about our time? When I've analyzed this for myself, I thought time is the veritas of healthcare in a lot of ways. That's what makes it work. Time. So I did a veritas analysis and asked myself, what's in the way of time? And I came up with 3 basic things: forms, fast administration, and lousy electronic health records that take all our time. So this is the practical part now going forward into the future that I think we can actually do something about this. By forms, I mean these screens, logins, alerts, emails, and scripts that are based on the principle that all of us, I'm sure, have heard: if it's not documented, it didn't happen, but which psychologically gets turned into, if it is documented, it did happen. And when somebody is faced with doing something or documenting it and they only have the time to do one or the other, they're going to document it. And the second one is what I call fast administration, or a problem with style. I don't know if you can see this, but it amused me. I found this great picture of Gulliver and the Lilliputians that he's tied down with all these little strings. And the problem with style, the style is the administrator's idea that if you just send a memo, you've solved the problem. Pass a regulation, make a form, it's done. And the last one, and I think the lowest hanging fruit to get our time back short term, is to fix our electronic health records, which have turned out to be unbelievably inefficient in their efficiency. Stanford did a study that showed that they take 70% of your doctor's time sitting in front of that thing. But Kaiser did a more recent study where they actually kept track of their doctor's keystrokes in 2 different hospitals for 2 months. All the keystrokes of all their docs. And then they divided that by the number of doctors, and they discovered that doctors were spending 10 hours of their 8-hour day on the computer. 10 hours of their 8-hour day. They were all going home. All the docs I know told me this. This is true. They go home, and from 8 to 10 they work at home. So I think we need to fix them, and I think there's simple ways to do it. And the last thing is to nourish our Veritas by just experimenting. And this is what I'm talking at different hospitals about encouraging them to do, is just have some experiments where they just give their doctors back their time and see whether they save money. You know, they could start a slow medicine clinic, for instance, where they just hang up a shingle that says slow medicine clinic and give the doctor a schedule or her schedule and keep track for a year and see whether that doctor orders more tests or less tests, whether that patient's on more medications or less medications, whether there are fewer ER visits or more. Slow medicine beds in the hospital and a slow medicine consult service we can talk about. And in the end, I have to tell you, I'm not a pessimist exactly about healthcare. I'm a pessimist and an optimist. So we have done a fantastic job with fast medicine. I mean, nobody in this room, and certainly not me, would want to go back to any past compared to now as far as medical care. I mean, it's fantastic what we've got. But on our way to our slow medicine, or to our fast medicine utopia, we've kind of, I think of the slow medicine having fallen off our wagon without us noticing. And we have to go back now and pick it up, because we can have both of these principles together. So I just wrote this book, and in the end, I think we need to remember who, in the end, won that race. Thank you very much.
Any questions?
Comments?
Comments?
Could I be her doctor?
Yes.
Can you tell us a little bit about the sanatoriums that were in Marin County and Mill Valley?
I wish I could, and I bet you there's somebody here who knows more than me. I couldn't find very much in my little bit of a scan. I mean, sanitariums in general, but I don't know anything really about Marin's, honestly. Well, in general, so sanatoriums are places for health, right? That's what sanos means, healthy. And they were many of them were started out as tuberculosis sanatoriums, right? Because it was discovered, what happened with TB is, well, isolation, but even more than that, for the sunlight and the fresh air, and the good food and the sleep. What was noticed is, what we call tuberculosis today wasn't exactly what they called tuberculosis back then, because a lot of the sanatoriums were actually before Koch and his postulates and the bacillus and the microscope that discovered the germ. But what was discovered starting around the 1850s is they were getting more of what they called tuberculosis as people crowded into the cities, as they had less sunlight, they weren't farming anymore, they were in the big tenements. That's who got tuberculosis. And so, because it was kind of an allopathic idea, right, if you get something by being crammed up, not having enough food, no sunlight, let's do the opposite. And they found that if they would send people to the mountains, the high mountains with sunlight, and get sunlight, they'd wheel them out and put them in the sun, that patients recovered, which is really interesting. I mean, they did recover in the tuberculosis sanitariums. I actually don't know. I think of it mostly as tuberculosis sanatoriums, so I expect that word was used for other diseases, but that I just think of it as tuberculosis sanatoriums, so sure. Yes, sir.
No question, I just want to comment. I'm a physician 38 years of practice. And I quit because the electronic health record was driving me insane.
Yeah. Yeah.
Not to mention depressing.
Yeah.
I loved medicine up until, with some small exceptions, up until the health record finished me.
Yeah.
It just made me feel like my hand was being tied behind my back. So I feel like you hit the nail on the head in your description of what's wrong with current medicine. The health record has some clear benefits, but just the way it interferes with the doctor-patient relationship, I thought was just so disturbing that I couldn't handle it. So I
Yes.
said goodbye, and now I'm out hiking and running everywhere.
Yes, well, we'll leave that part out. So this is a gentleman who was a physician or is a physician, 38 years of experience. And one of the things about being a doc is, it's one of the few places where the older you are, the better you get. The less meds you use, the more you trust your judgment, and your judgment's correct. I mean, my whole generation is retiring in droves way before we thought we were going to retire. And we're the ones you really want to be your doctor, right? And why are we retiring? We're retiring because almost always because it's not money, it's not tired. People want to practice. These electronic health records are a scandal. It's a scandal. And the reasons it's a scandal is because they're not really about health records. They're about data. So what's happened is doctors are being free data providers to the electronic health record companies, will scoop up that data and sell it to the marketers and advertisers. That's actually how they make most of their money, the electronic health record companies. So that's the problem, but the solution is actually pretty easy. And I actually went to Google last week to kind of tell them how we need to have electronic health records. So I told them it's very simple. There were two advantages to electronic health records that are obvious, right? The biggest problem with our old-fashioned paper records is if they were here, they weren't there, right? That was the main problem. So the least that we could be able to do is be able to have is use electrons for what they're good for, right? But the problem with the way they were put together is they were built on an old-fashioned billing system. They were literally built on this antediluvian code that was started to be billing in the 80s, and they just piled. And as far as I know, every single electronic health record anybody showed me, they're essentially all the same. You're hunched over, you're filling in little boxes, you're logging in, you're waiting for something to turn. It's a disaster, and all doctors are data providers. Now that data is valuable, and we're not going to be able to not do that. So my thought is that the electronic health record should have the structure, speaking of history, of the classic narrative tool, which is a book. It's called a codex in the Middle Ages, the thing that goes pages, that turns. I felt as a doc that being able to write in that paper book that was a paper that had pages that I could turn, I could look at people's handwritings. I knew just by looking, and so did Anne, and so did Marie. We knew exactly, just by flicking, I knew who was writing all those notes and exactly how much credence to put into what they wrote, mind you. That's true. And it didn't force us, it allowed us to have a narrative to tell the story of the patient. Because really, the diagnosis and the story are the same thing. If you get the story right, you get the diagnosis. The diagnosis is the story is the diagnosis. And having something that's not a narrative, but is just crumpled into thousands of little pieces, is completely, you can't figure out what's going on. So that's the other piece. Not only is it driving doctors, your experienced, wonderful doctors completely out, but they are useless to actually try and figure out what's wrong with the patient. My father was in the hospital. I start this book with his admission where he had the wrong diagnosis. And long story short, eventually I asked for his medical records. He was in the hospital for 10 days, and they sent me 812 pages of an electronic health record. And I spent 4 hours with that, just trying to understand how he got his wrong diagnosis. And after going through 812 pages, I still could not tell you how it happened. I couldn't tell you what happened. I couldn't tell you what medications he was actually taking. I couldn't tell you anything. So it's actually dangerous. So what do we need in an alternative? The alternative is to have, this is what I'm trying to convince Google to do, or somebody to steal this thought, is have a paper chart, like a paper chart, but it's made out of electricity. It looks just like a paper chart, so it's like an ebook, right? And you could be stored in the HIPAA-protected cloud. And then if you were my new patient and you came in, I would take one of these empty ebooks out and write your name in it. You know, you'd be that. And then if I wanted to write in it, I could write in it or type in it or dictate to it. And when I was done, I can put it back in the cloud. And then if you go to the lab can take it out of the cloud and put your labs in it, metaphorically, right? Metaphorically. But if you go to Paris and you get a broken leg, then Paris, they can put it in. And the data, if they want to collect the data, they need to insert AI. If artificial intelligence can do anything, it should be able to take our notes and turn them into data and fill out the damn forms itself. Like, what do I have to? That's it. That's what I think about electronic health records. Yes, sir.
I'm a physician, and I retired a year ago after 50 years of practice in the desert called Orange County. And I've entered the promised land. What I find is missing is I entered a profession way back in 1962. That profession has dissolved. There's no professional respect for the profession. What there is a focus on healthcare as a profit center. They are incompatible because what we are dedicated to as physicians is what is best for our patients, not what is best for the bottom line. And I'm wondering if that very old-fashioned notion is being put into effect when wise people select the medical students who will be the doctors of the future. Will they be some sort of electronic plug-in, or will they have a heart and want to help people?
Well, I'd like to say two things about the very eloquent. I think that's 50 years. I mean, wow, it's really amazing. So, two things that I'll say, and I don't know if other people here, but I do teach students, and I've also had the chance to go around. I've met wow. I mean, the medical students are fabulous. The nursing students are fabulous. The social work students are fabulous. This whole younger generation is fantastic, at least the ones who come to my talks. I mean, I'm sure they're ones, right? But I mean, they're wonderful. And we're setting up a terrible situation for them because they're being picked for their humanism as well as their scientific prowess. They're being told in medical school to be the kind of person you're talking about, and then they're put in a situation, exact same position you're talking about, only 50 years later, where, not 50 years later, but now, and they can look forward to the 50 years of not being able to do it. I've had them write me, Dr. Sweet, I want to practice slow medicine. I look around and I see my residents all the time on the computer. I don't want to do that way. Where can I go? So I'm really quite concerned about it, and it's actually one of the things that gives me the energy to kind of do all this, because I really want it to change, and I think it can change. But that leads me to a really quite disturbing, I would say, discovery I've been making. So I've been asking myself your same question. How did this happen? How did it happen that medicine's just treated as a commodity? I went and talked to healthcare economists. I've finally, and so it's sort of shocking what happened. So first of all, it was deliberate. It was deliberate and conscious. In 1975, the Federal Trade Commission wrote a challenge, essentially ordered the AMA to DC the professional list of ethics. They ordered them to. And the AMA fought it and lost in the Supreme Court. Okay? They said that when there was ethics, that they literally said that medicine was not one of the learned professions. It was a commodity. It was a business, and it would only be better for the consumer if everybody got to say and advertise, and with everything was just a commodity. So when I've read that now, I find very disturbing, but at least it pinpoints it. It's not an illusion. It was really deliberate. And so I'm kind of in the midst now of tracking that down, because what interests me to that is I want to know, just my own general principles, right? Who was on that FTC? What happened to them? What'd they get out of it? And what was interesting, so it wasn't an accident. It wasn't just happenstance. It was deliberate and conscious and on purpose. And what I will say, interestingly enough, is that the AMA took it all the way to Supreme Court. Supreme Court ruled against the AMA in 1982. In 1982, there were about 100 urgent care clinics in the whole United States. In 3 years, there were thousands. Why? Because this hedge fund guy who had been doing fast food went, oh, wow, we can just have this so this thought I've had that we have a fast food model is not it is in fact a fast food model. They actually took that model once healthcare was declared to be healthcare and not medical care and a commodity, and applied it. Like logically, did it on purpose. And this thing with CVS bringing us to the present is a fucking disaster. You guys are all ex-hippies or proto-hippies or son of hippies. I mean, it's just, the CVS thing is outrageous. Yes, sir.
The United States is the only developed country in the world that doesn't have universal health care. In most other developed countries, the doctors don't focus on what the insurance is, they focus on the patient. Is it your impression that some of the things that you've talked about are or are not the case, for example, in Europe?
That's a very good question about this comparison with Europe. Definitely much less, but it's more complicated than you would think, actually, because I'll just give you, this is actually a big discussion, and I don't want to go into it. We don't have very much time left, but I think some of this, yes. We've got like cowboys out there. They have bureaucrats. The bureaucrats are doing the same thing, but it's just not as much because they can't, there's not the same impetus behind it. And by contrast, I'll say Switzerland has a system. Obamacare was actually modeled on the Swiss system. And the Swiss does not have universal health care in this, I think, in the way you're talking about it. They have insurance, they have private insurance. They've controlled it. But the reason they've controlled it, I think, is just this general sense of the way the Swiss are. And I'll give you one, and then I'll hand it back, which I was struck by. So my partner's Swiss, and I lived in Switzerland for about a year, so I kind of have an understanding of a little bit of it. So here's what I was struck by when I was in Switzerland is, turns out in Switzerland, they believe that they actually have a ratio of CEO pay to the lowest person in the business. And it's not supposed to be more than about 10. It's not a law, because Swiss doesn't work that way, It's just not, it's sort of tacky. So this idea, it's just tacky, it's just not done. And there's a level in which what you were talking about, this profession, what I was talking about, this tradition, this understanding that we were embedded in a tradition that isn't about making $500 million, which is what that CVS guy is gonna make, by selling that whole thing completely down the river. So I don't think it's necessarily only, I think there's different working pieces of this. It's not just one little giblet that you could push in. Okay.
I'm so sorry. We're going to have to close the Q&A now, but we'll have a little time after the music. Okay? Victoria, we have Victoria and two other doctors here. We have a special song for you tonight, and we thank you for all your hard work, and we apologize for all the frustration. We've got Kay and Matt, and you may recognize this song. Okay, do you need the mic?
No, I don't think so. Can you hear me?
I'd like to get it recorded.
That's safe. Nice to see you. Yeah, he's recording this over there.
Okay.
Yeah. I have a comment.
Okay.
I'm a school teacher. follow me. So I wish this was better in the education. And I've added a verse to the song.
You just showed it to me.
After your brilliant.
Oh, help me, please, doctor, I'm damaged. There's a pain where there once was a heart. It's sleeping, it's beating. Can't you please tear it out and preserve it right there in that jar? Oh, help me, please, mama, I'm sickening. It's today, the day of the plunge. Oh, the gal I'm to marry, she's a bow-legged cow, and I've been sucking up to drink like a sponge. Don't you worry, get dressed, cried my mother, as she plied me with bourbon so sour. Pull your socks up, put your suit on, comb your long hair down, for you will be wedding me out. Oh, help me, please, doctor, I'm damaged. There's a pain where there once was a heart. It's sleeping, it's beating. Can you please tear it out and preserve it right there in that jar? Well, I was trembling as I put on my jacket. It had creases sharp as a knife. I put the ring in my pocket. There was a note, and my heart, it jumped into my mouth. Hey, Red, darling, I'm sorry to hurt you. I've no courage to speak to your face, but I'm down in Virginia with no cousin Lou. There'll be no wedding today. All right. So help me, please, doctor, I'm damaged. You might have heart in its hole. Oh, mama, I'm crying tears of relief, and my pulse is now under control. There's one that Nick Keith did right. Oh, doctor, please help me, I'm dying. The diagnosis is lost in my chart. I'm bleeding, barely breathing. Healing's a dying art. Hold my hand and listen to my heart.
Thank you very much. So appropriate. Victoria, thank you so much for coming to Mill Valley and to help us understand this crazy world we're in now. And thank all of you for coming tonight. We hope you enjoyed the show.